Now, the title says sepsis, making leading practice common practice, and really that is the theme that we have in the clinical services group. How do we make that? How do we hardwire in practices that we know improve patient care? And that's a very difficult area. So after we finish the CME program, we'll all be more in tune with the early signs and symptoms. We'll how to identify timely treatments for severe sepsis and cite some key elements that I think make an effective hospital program, because ultimately the implementation of a sepsis program has to be locally based on your workflow, based on your resources, and based on your patient population. And I can tell you from all the hospitals I've been to in East Florida, each one of you are unique and special in your own way. This particular slide, I think, highlights an important space that I work in, both in my teaching responsibilities and my work at HCA, and that is this patient safety quality space that we all work in. And on the left-hand side, you'll see patient safety, the absence of bad things happening, and that really fits into infection prevention. And we have two of our infection preventionists here this evening. And really, when our patients come to the hospital, if we can prevent them from getting infections, you'll see in a minute, that's really extremely helpful. On the right-hand side is if things are happening to patients, we do the right things at the right time with the right evidence-based interventions. And then in the middle, sort of really bridging both of those areas, are antimicrobial stewardship, which is a topic in and of itself, and which I was here about 2 years ago. Well, this is the facility that I work and play in when I'm in Houston, which is where I physically live, even though my corporate office is in Nashville. And I still have the privilege of teaching and seeing consults with our house staff. And what I'd like to do first, before we start about some of the science, is to present two cases that I've recently seen for discussion. So this is a 34-year-old African-American male admitted back in October with weakness, leg pain, fever, and hypotension. He was sort of a complicated patient. He'd been hospitalized for 6 weeks earlier for renal insufficiency and hypertension. He underwent a renal biopsy, and he was found to have focal segmental glomerulosclerosis. And for that, he was placed on prednisone and cyclosporin. So he was, if you would, immunosuppressed. On admission, he had a blood pressure of 80 over 40. He was tachycardic. He was tachypnic. He was febrile. His O2 sat were not terribly good. It was only 85%. He had decreased breath sounds at his left base. He was not icteric. He had no murmurs. The abdomen was benign. But his lower extremity was impressive, although he didn't think it was impressive, but to me it was. He had some mild swelling and erythema on the left lower extremity. Now, he was dark-skinned, and so it was a little bit more subtle than it might be in someone with lighter skin. But the impressive part of his exam was his disproportionate pain that he experienced on his lower extremity. He was intubated in the emergency department and was sent to the ICU. I think everybody here would say this guy's sick. All right? So his initial laboratory, his white count was only 6,200, but he had 17% bands. His albumin, get this folks, was 0.4. Now remember, I said he had glomerulosclerosis, and I did not tell you he actually had nephrotic syndrome as part of that. So because of his acute illness and because of his protein loss, you could say his colloidal pressure was pretty low. His creatinine was 3.8. His baseline creatinine prior to getting this sick was around 2. And his lactate level was 4.9. We'll come back and talk about that, but that's an elevation that we're concerned about. But look at his bicarbonate level. His bicarbonate level was 24. We would probably, in our lab, consider that normal. His PT and PTT were mildly abnormal. His fibrin split products were elevated. And he did have a left pleural effusion consistent with his physical exam. The emergency department, I'm sure that this doesn't happen in East Florida, but in our emergency department, everybody who's sick gets put on vancomycin and piptazo. Does that happen here? Come on, pharmacist. Yes or no? Mirum, okay. Mirum. By the way, I'm not being critical, but I'm saying this is a very sick person, and this is a very common combination that we see in very ill patients. So after 1 or 2 days in the intensive care unit, while we're trying to, if you would, resuscitate him, He developed some further changes in his lower extremity, and I'm going to show you that picture so you can take a look at this. And we'll come back and talk about the management of this patient and maybe what changes might have been appropriate for him therapeutically. Case number 2 is a little different scenario. A 24-year-old Hispanic female who came in with a 2-day history of dysuria and abdominal pain and flank pain. She was an insulin-dependent diabetic who didn't take particularly good care of herself. She was sexually active. She had a history of having recurrent UTIs in the past. And she said about 1 month ago she was treated for, quote, mastitis. She's not really sure exactly what she got, but it sounded like it might have been trimethoprim sulfamethoxazole. She was a little bit febrile. Blood pressure was slightly low. She was certainly tachycardic. She was, had tachypnea, and she had classic left CVA tenderness. Her white count had 13,000 with 13% bands. Her blood glucose was elevated at 303. Creatinine was okay. Urinalysis showed polyuria, hematuria, bacteriuria, small ketones, and her lactate was 3.8. So that was that case. And this is her CT of her abdomen. The folks were concerned that maybe she had obstruction, and we'll come back and talk about the CT at the end of the hour. So the question for this group is, what's her diagnosis, and what would you empirically start in a patient like this with her history? And you'll see why I'm asking those questions as we go through the presentation. So what we're going to do is we're going to talk about sepsis, early recognition and tools, the role of antibiotics. I actually, believe it or not, believe in the germ theory. We're going to review the literature on hemodynamic resuscitation and early goal-directed therapy. We'll discuss the role of lactate monitoring, which I'm sure you're all very familiar. I assume you have all point-of-care testing lactates in your ED. The role of the pharmacology of vasopressors. Look at the literature around outcomes, discuss the evidence-based use of steroids, review the literature on outcomes, and describe some keys, I think some keys, for implementing a successful program. Now, I like this quote by Thomas Huxley, that the great tragedy of science is the slaying of a beautiful hypothesis by an ugly fact. Now, I've been involved in sepsis since the early 2000s in a project called the Transformation of the ICU. And half the interventions and evidence that we used between 2000 and 2003 have changed or been discounted. And when I do a workshop on this, which some of you have heard me give, we go through the evolving science around sepsis, and I'll mention a few of those facts as we go. So Sir William Osler, which I think most of the physicians in this room remember, was very smart because, they didn't know about all the biochemical and other things that happen in sepsis. Said, except on a few occasions, the patient appears to die from the body's response to infection rather than from it. And it turns out he was right. I'm not going to go through too much of the basic science here. So basically, we're talking about gram-positive organisms and glycopeptides that go through what's called a toll-like receptor into the macrophage. The gram-negatives go through a toll house receptor 4. Anyway, the activation of macrophages, primarily what we call cytokines, TNF, IL-1, and you can see the other cytokines, are really responsible for many of the things we see with sepsis. I don't want to get too deep into this, though. But now, the reason that sepsis is so important is, in fact, it's the #1 cause of death in non-coronary ICUs. And as you can see from this slide, the growth in number of total cases in the U.S. is going up much faster than the U.S. population. And if you look at the incidence compared to many other common clinical syndromes that we face every day in the hospital, you can see it's actually more common than heart failure and has a mortality, which I'll tell you now is still higher than I'd like to see it. And actually, we've made a lot of progress on acute myocardial infarction. And we're beginning to make progress with sepsis as well. This is probably the most recent data about hospitalization rates with sepsis that was carried out from 2000 to 2008. You can see both of these lines are going up substantially. The bottom line are hospitalizations for sepsis. Those are patients that come in through our ED, and a good percentage of our patients come in through the ED. The top line are all patients who either come in with it or develop sepsis while they're in the hospital. And you can see both of these lines have really showed a sharp inflection up as we ended the last decade. The other thing that's driving this, and this is particularly important for those of you who live in Florida, is the age. Now, you don't have any elderly patients here, right? No. Okay? And there are no nursing homes, right? No. Okay? So you can see a lot of this is driven by the fact that we're living longer. We have lots of octarians out there. A lot of them have chronic diseases, but you can see that is where the biggest increase is coming in terms of sepsis. And if you look at through the ED departments, and I'm assuming that a lot of your admissions come through the ED, what percentage of your admissions come through the ED in the hospitals that are here? Anybody knows? Yeah, that's pretty common. So if you look at, this is the Health Grades database from 2010, and if you look at patients who are coming through the ED with sepsis, and you look at the numbers here, and then you look at pneumonia, which is a very common diagnosis. Pneumonia is more common, but I want you to look at the mortality rate. Mortality rate is much higher in patients who come in with the diagnosis of sepsis than people who come in with pneumonia. And then in the project that I was involved in called the Transformation of the ICU or TICU, this is where our database said about a third of our patients came into the emergency department, a third developed sepsis while they were on the floor, and the third were a variety of areas, that's 16%, and others, a lot of that was in the intensive care unit. So the question that we raised is, what processes and system does your hospital have in place to ensure early recognition and treatment of severe septic patients? Now, we have relative control in patients who come in from the ED. We have some control, I know we have some ICU folks here, right? Of folks who are in the intensive care unit. But I want you to look at a third of those patients who actually develop severe sepsis that are on the floor. And I want you to think about that just for a moment and what things that you're already implementing that you may not realize may be a very useful tool. You've all seen curves like this, that not everything that it's called systemic inflammatory response syndrome, which I will define in just a moment. Not all of them, in fact, are sepsis. There's a lot of other things here on the right side of the slide, including pancreatitis, trauma, burns, tissue necrosis that's non-infectious that can produce a syndrome that looks just like severe sepsis. There's a whole lot of people here on the left that have infection that don't have all the SIRS criteria. But right here in this middle part, this is the group that really has the highest morbidity and mortality and that we're really trying to focus to try to impact. And here's the criteria, which I think most of you know. On the left-hand side, it's fever or hypothermia, tachycardia, tachypnea, elevated white count or low white count, and or increased number of immature neutrophils. Now, let me also caution you, and we talked about this when I was at IRL today. If you're looking for bands, the way to order that is ask the lab to do a manual differential. Don't rely on what comes off the computer readout because it's misleading. So if you've got two of those criteria or more, you've got SIRS. Remember, pancreatitis, trauma, tissue necrosis can all produce a syndrome just like that. But it's got to be due to an infection. So if you've got SIRS plus an infection, we call that sepsis. And sepsis is a term that is fairly loosely thrown around by all of us. Now, it's severe sepsis if we have one or more organ dysfunctions, and we'll kind of go through this in a little bit more detail about what constitutes organ dysfunction. And we call it septic shock, that if after fluid resuscitation, the patient remains hypotensive. So that's the international criteria that was developed by Roger Bone back in the 1990s. And again, if you look at this pyramid, and you look as you go up this pyramid, the sicker you are, guess what? The higher your risk of death. Severe sepsis, about 20%. If you go up to septic shock, especially if it's recognized late, the mortality rate may be anywhere from 45 to 50%. Now, I want you to look at the date of this publication. This is 2003. We think we can do better, especially with the top part of that pyramid. It's also going to be a very subtle or deadly disease, and people will progress at faster or slower rates, which is why early recognition is so important, because the later on in this course of disease, as you can see, there's a stepwise increase in mortality. If you look at organ dysfunctions, the number of organ dysfunctions also has a direct impact on mortality. These are two separate studies with almost identical findings. It makes sense. The more organs that aren't working, the sicker the patient is, the more likely you are to die. If you have 4 or more organs that are not doing well, you're really circling the drain. And so you can see that the earlier you can intervene on this scale, and the better you can preserve organ function, the better your patients are going to be. So the summary of this first part is that the number one cause of death in non-coronary ICUs, the incidence of severe sepsis has certainly increased in the last decade, especially in those individuals over age 65, and that historically there's at least a 45% mortality associated with septic shock, but as I'll show in a little while, I'm happy to say we've made some progress on that. So what's the goals of treatment of severe sepsis and septic shock? The first one I've already alluded to is early identification. We'll come back and talk about that. Obviously, appropriate antibiotics. Source control is important. If you've got an abscess that needs to be drained, you've got a line that needs to come out. Resuscitation with appropriate fluids. One of the challenges, especially in your population that you treat, and I'll have a slide that addresses this, what do you do about someone who's got a history of congestive heart failure and comes in septic shock? How much fluids can I give them? Is that a question that ever comes up? Yeah, okay. Vasopressor, what vasopressor, and what other emergency supportive care for that acute organ dysfunction is appropriate. So the new sepsis guidelines came out in February of this year, were updated, and I will tell you the recommendations are primarily based on the early quantitative resuscitation of sepsis during the first 6 hours after recognition. The old guidelines had a resuscitation part and it had a maintenance part. This guideline focuses primarily on the first 6 hours. Time is tissue. I'm sure you've already heard the concept door to needle time for acute myocardial infarction, strokes. Think of sepsis in exactly the same way, that the longer you wait, the more tissue dysfunction and damage occurs. And if you don't screen, you'll miss the patients early in the course. And that tissue hypoxia sometimes is pretty occult. It can really reach an advanced stage even before the presence is known and resuscitation is attempted. And that last bullet point's important, that sometimes up to 50% of people resuscitated with shock may have continued global tissue hypoxia, and we measure that by lactate or decreased SVO2, which I'll talk about in a minute. And a lot of times they can initially come in with normal vital signs and normal central venous pressure, which is why we rely very heavily on lactates. This is the typical old way we screen people. We did it on paper. This is how the transformation of the ICU did it. So twice a day during the shift, nurses would come down, look at the service criteria, look to see if it was an infection, looked at the end organ damage, and these are the definitions for end organ damage, such as blood pressure, PF ratios, urinary output, hepatic liver enzymes, hematological stuff, pH and lactates, and altered mental status or reduced Glasgow Coma score. Now let me give you a caution here, and we're going to talk about screening in a moment. You have to think about the patient and use critical thinking. If I've got a patient who has chronic hepatitis and they come in and their liver function tests are twice the upper limits of normal, is that new? If I've got someone who's on Coumadin and their prothrombin time is elevated, is that new? And so look at these numbers and realize what we're really asking for is the abnormality we're recording, is it new? Because you can see many of the chronic patients that we see may have a quote, an organ dysfunction that's baseline. So just keep that in mind as you do the screening. This is a nice little thing I like to use to actually put up in the EDs and in the nursing units and in the ICU. It's a nice visual way for how people can look at organ dysfunction for severe sepsis and help them. I'm a visual person. I sort of like stuff like this rather than just a checklist. But whatever works best for you is fine. You know, when we go through this in our more workshop environment, we go through the problems with screening and the problem with sensitivity and specificity. The screening tools that we use are relatively sensitive but are not very specific. And there's a high false positive rate when you do the screening. I don't know if anybody here in this room at your facilities are working with these screening tools, But would that be fair to say that there's false positives? And we've revised our tools multiple times to try to address that. This particular group looked at, well, rather than just say someone has SIRS and has greater than 2 of those criteria, what about the severity? Can we work on the severity and see if that's a better indicator in terms of specificity? So they came up with this tool that looks at, based on your heart rates and your respiratory rates and your Y count, and you see the more severe abnormality, either up or down, you get a higher number. And they screened it, and you can see that if they had a score greater than or equal to 4, this is in a surgical intensive care unit, the nurse completed the sepsis screening form and notified the physician. Sort of a code sepsis, if you would. And what they found is the screening tool, there was a slight drop in sensitivity. Sensitivity by the old tools is about 98, 99%. But the specificity went way up to 95%, which was pretty good. The predictive value, 80%, was very good. Negative predictive value was essentially 100%. But more importantly, when they implemented this tool, they lowered their mortality rate for all causes of severe sepsis and septic shock from 35% down to 23%. So there's no question that recognizing early signs and symptoms of severe sepsis and shock can greatly improve survival rates, that effective screening must be part of our daily workflow, that early quantitative resuscitation of the septic patient must occur in the first 6 hours. We'll get into that in a little bit more detail. And there must be a defined process for timely response to the screening results. So I want you to think about this, and I've challenged every group that I've worked with. Since Muse is a modified early warning system screen that they're primarily using on the floors. And if your Muse score goes up, 2 or more points or something like that, it's an early response for the nurse to evaluate the patient. It is very similar to this severity screening. The only thing that Muse has that this does not have, it has change in mental status. Okay, and in fact, the new screening tool that we're using in a group in Houston is using this plus altered mental status, very similar to Muse. So one of the challenges has been with the nurse-to-patient ratio on the floor is very different than it is in the ICU. It's very different in the ED. Can we leverage Muse, which we're using, to be an early warning for sepsis as well? So what about antimicrobial therapy? There's no question mortality is increased if the initial therapy is incorrect and not given in a timely manner. Now, this is a pretty scary trend, and Dr. Cologne will tell you, because she does all the wonderful microbiology that you get, that there are pockets of increased resistance in East Florida, right? And it's variable, by the way. You've got to know your own local epidemiology. We reviewed this data with Dr. Cologne earlier. But you're all familiar with MRSA, and that's number 1 on this. And you can see that the incidence of invasive MRSA has begun to level off and, in fact, has begun to decline a little bit through a variety of reasons. VRE has been remained kind of stubbornly slow, not really going up that much, but it's the dotted line that really scares the heck out of us. And that's those carbapenem-resistant gram-negative rods. And you do have some pockets here in East Florida. And a lot of these folks, by the way, may be coming from your nursing homes, which we have very little control over. And then the last one is increasing azole resistance to Candida, that is fluconazole. So that's a warning sign. We know that if we give the right drug, we reduce mortality. And this is 4 different series that shows that mortality is less if the initial drug is appropriate meaning it covers the eventual cultured pathogen. Now, this is a very important article that came out a year and a half ago that looks at the impact of previous therapy on outcomes of gram-negative severe sepsis. Now, how many patients do you think come in from nursing homes that haven't been on recent antibiotics? Not many, right? So you got a lot of patients like this. And patients who develop sepsis in the hospital probably have also potentially been on antibiotics. So think about that. So here's a case that if patients have been on prior antibiotics, the bottom line is Apache score. Apache score is an index of severity. The higher the score, the sicker the patient. So you can see if you've received prior antibiotic therapy, regardless of the severity, your mortality rate is statistically significantly higher than those who have not been on prior antibiotic for gram-negative infections. So the question is, Ed, why is that? And it's shown on this slide. On the top looks at, if you would, an antibiogram, a little snapshot. Antimicrobial agent on the left-hand side. These are all commonly used drugs in our facilities. Prior antibiotic exposure, no prior antibiotic exposure, looking at percent susceptibility. So for those patients who have been on prior antibiotic exposure, the percent susceptible is statistically lower than those who have not been on antibiotics. It's across the board. And at the bottom, you're much more likely to have a multi-drug resistant organism, which is defined as being resistant to 3 or more major classes of antibiotics. And on the bottom, when they did multivariate analysis, the 2 things that stood out about increasing mortality, one that you already know, that is prior antibiotic exposure. The second is inappropriate initial therapy. The reason it was inappropriate is that when you get into multi-drug resistant organisms, it's a little bit more difficult to decide what your empiric therapy should be. So as an example, if you have a patient who comes in from a nursing home, and they may have a multi-drug resistant Acinetobacter in that nursing home, you may not know it at the time, and the patient comes in with severe sepsis, what's going to be your antibiotic regimen? You've got to know your own local epidemiology. You have to know what kind of pathogens come in from that nursing home that are admitted to your hospital. In this case, I will tell you, it might be the fact that this Acinetobacter is only susceptible to colistin. Where's our pharmacy guy? Hi there, you like that drug? Love it, right? Okay. So empirically, I mean, I never thought I would be saying this. Empirically, on that patient, I might be using colistin. Now, why am I making this point? I'm making this point because the local epidemiology is so vital for what drugs you use at your facility. What may work at university may not work, down in Kendrick or other facility, Kendall or other facilities. So know your local epidemiology. It's also important to give the drug in a timely manner. And this is the famous Kumar study that basically shows with every 30 to 60 minute increment of delay that the mortality rate goes up substantially. So the standard of care now is you give that first dose in patients from the time of hypotension within 1 hour. So what do the new sepsis guidelines say? They say, first of all, that blood cultures ought to be done prior to the first dose of antibiotics. What a novel concept. Now, let me warn you about this. It sounds simple, but operationally, when you're trying to get that first dose of the antibiotic in so fast, and I don't know how your ED works, but in some places the phlebotomists draw the blood cultures and the nurse hangs the antibiotics. So they're so much in a rush to get that first dose in of the 4th generation gorillamycin, and they get that dose hung up, and the blood culture bottles are sitting at the bedside table and never get drawn. Let me make a plea to you, especially in an era of more multi-drug resistant organisms, send the appropriate cultures in a timely manner to the microbiology lab before starting antibiotics. Now, if the site is difficult to obtain, like a sputum, don't delay giving the antibiotics if the site is not accessible. But bloods generally are accessible on everyone. And in a septic patient, especially one with septic shock, about 50% of people with septic shock have positive blood cultures. So it's a rich source, and you can figure out what the pathogen is, and you can do pathogen-specific therapy and de-escalate once you get the results of the susceptibility. So you may start the patient on colistin, but it turns out, hey, it's sensitive to trimethoprim sulfa, okay? So you want to give that first drug within 1 hour based on the local susceptibilities and the site of the infection, et cetera. De-escalate. These, by the way, have very high level of evidence. And then there's source control. And that's important. If you've got an abscess that needs to be drained or you're coming from a line, that you want to get those out in a timely manner. Now, what about the hemodynamic resuscitation, the so-called early goal-directed therapy? This is the initial resuscitation package in the new Surviving Sepsis campaign. Begin resuscitation for arterial hypotension and a positive sepsis screen. Those are the positive screen. Systemic blood pressure is less than 90, mean arterial pressure less than 70, or the systemic blood pressure is decreased by at least 40 from their baseline. So if you have a hypertensive patient that blood pressure systolic is around 180 and now they're 110 or 120, that's a significant decrease in that patient. You may or may not know their baseline rate, but if they've been in the hospital, you can follow that. The next thing is you want to do fluid resuscitation, and the standard is with crystalloid. Normal saline, Ringer's lactate, not head of starch or any artificial, which actually impairs renal function, and not the use of albumin. The fluid challenge should be 30 cc's per kilogram of crystalloid. That's a change from the 2008 guideline, which was 20. Again, more rapid administration and greater amounts of fluids may be needed in some patients. Continued fluids challenge as long as you see improvement. Now, one of the biggest mistakes is not giving enough fluid. These people are severely intravascularly depleted. This is the early goal-directed therapy that Manny Rivers published in 2001. You probably are all familiar with this. These are patients who had septic shock despite resuscitation by the old 20 mLs per kilogram, or had a lactate of greater than 4. We'll come back and talk about the significance of that in a moment. The standard therapy is what we were using for decades. Put a CVP line, try to optimize our fluids to get a CVP between 8 to 12. Vasopressor if they remain hypotensive. Try to maintain a urine output of greater than 0.4 mLs per kilogram per hour and get the mean arterial pressure up to greater than 65. But Dr. Rivers added a second component in half of his patients. He said, we're going to do the standard care, but we want to try something more. So we're going to monitor the CVT, but this time we're going to put a special catheter in, and we're going to measure SCVO2s, which is a measure of cardiac output and other things. If it's less than 70, and you'll see the significance of 70 in a moment, we want to make sure we get their red cells up with their hematocrit greater than 30, because you know red cells carry oxygen, right? So if the crit is less than 30, he would give red cells. And if the SVO2 is still less than 70, despite that, he added a positive inotropic drug called dobutamine. So that was early goal-directed therapy. This is the monitoring equipment you need. I think all of our facilities have this in place now. And so what Manny found was, in his study, was that number one, early goal-directed therapy, because he was really much more aggressive with fluids, you can see he gave more fluids than traditional therapy would give. And so you can see the fluid was about 1.5 liters more in early goal-directed therapy. As you might imagine, there were more transfusions because he kept the crit greater than 30. Presses were the same, and of course, dobutamine, prior to this point, was not a common part of the resuscitation package. So obviously, much more use of dobutamine. More importantly, what were the outcomes? The outcome was a significant reduction in in-hospital and 28-day mortality rate, a third decreased risk of deaths in 60 days, all of which was statistically significant. Now, this study has come under some scrutiny, to be quite intellectually fair. Initially, it was only a single center. In Dr. Rivers' group, if you look at his folks, they had higher lactates than most facilities, which this was an inner city in Detroit. So they had higher lactates and they had lower SCVO2s than many other studies have shown. It's invasive. You got to put a catheter in. The uptake, I can tell you, of the protocol has been quite variable across the United States. And there's currently 3 trials that are underway in Europe, US, and Australia to sort of replicate this. Having said all of that, and I'll show you some subsequent studies that have come out more recently, there is broad agreement that careful attention to rapid resolution of shock or organ underperfusion is a key component of good care, regardless of what you do. Now, this is a study that came out the end of last year. It looked at the Genesis trial, which is Generalized Early Sepsis Intervention Strategies, and it involved 5 community hospitals and 6 tertiary facilities using early goal-directed therapy. So the one criticism, there was only 1 academic medical center that did this. Now we've got 11 facilities in here, half of which were community hospitals. The same resuscitation package that you see here that was used in early goal-directed therapy. More importantly is what happened to the mortality. This is when this was beginning to be implemented here. Here's the original Manny Rivers, where there was a 45% mortality rate. You can see over time the mortality rate has come down to less than 30% for all comers. And then when they adjusted for predictors of mortality, they found a significant association between SVO2s. Getting them greater than 70% at 6 hours was associated with improved outcomes. Mean arterial pressure greater than 65 at 6 hours, and the lactate measured all were associated with reduced mortality. Now, SVO2 can be a measurement and predictor of mortality. If you're hypoxic, which is defined as an SVO2 of less than 70, the mortality rate can be 40%. If it's between 70 and 90, you can see half. But having a high SVO2 may be bad also, because it may represent the inability of the cell to extract oxygen, or there may be significant microcirculatory shunting due to sepsis and microemboli. So the sweet spot is 70 to 90. Now, one of the criticisms of the Rivers protocol was the issue about transfusions. How does transfusions fit into this improvement? Never been tried. This was just based on opinion. Sounded logical. Let's improve oxygen delivery to tissue by increasing the red cell count. We all know, and I haven't shown you in this slide deck, that actually red cell transfusions in the ICU can be immunosuppressive and are actually associated with a higher infectious disease complication rate. Finally, the Surviving Sepsis campaign at the end of last year looked at red cell transfusions alone as a part of the resuscitation package. And what they found was that the transfusion of red cells was not associated with improved cellular oxygenation, as measured primarily through the SVO2 route, and that transfusion of red cells was also not associated with improved organ function or improved achievement of other goals of early goal-directed therapy. So finally, I think we've put this one element to rest, that keeping the crit above 30 is not essential. And here's the slide about red cells and mortality. If you look at multiple studies, the pooled mortality, you can see the mortality rate is twice as great, or the risk of infectious complications is twice as high in those patients who receive red cell transfusions. Now, I happen to love this curve. This is from Louis Vincent, who is a wonderful critical care specialist in Belgium, very well known, who wrote a very thoughtful editorial in response to all this red cell stuff. And really, I think this really, to me, says it all. He divides folks into folks who are younger or older, and those who may or may not have coronary artery disease. The sweet spot by most literature is the hemoglobin between 7 and 9. And the question is, where in that amount do you give transfusions? Well, this seems very logical. If I'm 70 years of age, and I've got known coronary artery disease, I may have a lower threshold for when I give red cells. So if I'm at 8 and 8.5 grams, and I've got evidence of some myocardial dysfunction, maybe that's a patient I ought to be giving red cells to. If I'm 20 years old and I have a hemoglobin of 7.1 and I'm otherwise healthy, that person may not read red cells. So this is a very nice conceptual way about guidance for red cell transfusions. So where did the new Surviving Sepsis campaign come down? That once tissue hypoperfusion has resolved in the absence of extenuating circumstances, such as myocardial ischemia, severe hypoxia, acute hemorrhage, ischemic coronary artery disease, we recommend that red cell transfusions occur when hemoglobin concentrations are less than 70 to target concentrations of 7 to 9, and the recommendation gets a category 1B, which is a very high level of recommendation. So crit greater than 30 is out, look at myocardial disease, look at age, decide whether or not you transfuse at less than 7, or in some patients, as it says, use critical thinking here. If you've got some myocardial ischemia and the hemoglobin's 8, you might want to transfuse that person up to 9. If they're otherwise young and healthy, up down to 7 is probably fine. So here's the summary then of the resuscitation bundle. And this is going to become important when we start talking about measurement. To be completed within 3 hours, measure your lactate level. We haven't talked about lactate, but we'll come back and talk about that. Remember about getting appropriate cultures first. Administer broad-spectrum antibiotics within a timely manner. We've already said the standard is less than 1 hour. And then resuscitation with crystalloid at 30 cc's per kilogram, not 20. Then within 6 hours, Vasopressors if the patient still remains hypotensive, and we'll come back and talk about what the preferred vasopressor is. If they have persistent hypotension or initial lactate of greater than 4, and I want you to pay attention to this, this is a tiered approach. Not everyone who you identify with severe sepsis or even septic shock who responds well to fluids, who does not have lactates greater than 4, need this next tier of intervention. In fact, you're going to find out that the minority of patients require this. If they fit the criteria, you then want to target CVP levels in that first 3 to 6 hours to be greater than 8, and you want to measure SVO2 and you want to target that to be greater than 70%, and then you want to remeasure the lactate if the original lactate level is elevated, and I'll tell you why that is in just a moment. So that's the resuscitation package. So what about lactate? Lactate is a very good measurement of global tissue hypoxia, and it can be elevated despite normal vital signs and normal central venous pressure. In addition, lactate clearance is a very good prognostic. This particular study looks at 10%. You can see if you have greater than 10% lactate clearance, that your probability of survival is much greater than if you do not clear lactate with appropriate resuscitation. So that's why you should repeat that lactate level. Again, this article says exactly the same thing. These are the initial lactate minus the later lactate level, so that if you hear in group number 1, this group does not clear lactate at all. In fact, the lactate level continues to go up. Their mortality rate's 53%. You can see as you clear more and more and you go down to group number 4, the greater the lactate clearance, the lower the mortality rate. So lactate clearance is a very nice prognostic thing. It also measures how successful you are at looking at tissue hypoperfusion. And then there's that rare patient, by the way, that truly has septic shock, but they don't really elevate their lactates. And there's a subgroup of people who don't do that. And you can see that if they're one of those patients, you can see the probability of survival is much greater if their lactate is not elevated. Now, this has become somewhat of a controversial area, and that's the lactate clearance versus SCVO2. This is so far looking at lactate clearance versus doing SCVO2s and putting a catheter in. This was published in JAMA in 2010 by Jackson's group in Birmingham. They looked at lactate clearance of being at least 10%. They, by the way, which most people don't know, they actually use CVP levels, and one of their targets was making sure CVPs were between 8 and 12. And then they looked at lactate clearance. And if the lactate clearance in the first 6 hours was not greater than 10%, then they instituted all the other things of early goal-directed therapy. So they gave transfusions if their crit was less than 30. They gave dolbutamine, but they didn't necessarily measure SVO2s. And their results show that it was not inferior. This was a non-inferiority trial, but I want you to look at the numbers. They started off with 150 in each group, but they only had about 25 to 30 people that were evaluable. So the N was fairly low, but it is still an important study because in this particular counterpoint, and in the new Surviving Sepsis campaign, they do say that, SVO2 is preferred. It's been much more extensively studied. It got a 1C recommendation. But lactate clearance of greater than 10% may be a reasonable alternative if SVO2 is not readily available. We know there are patients that for some reason anatomically you can't get a line in. They have a hematological problem where it's dangerous to put a CVP line in. So there are a subgroup of people you can't. But again, the level of evidence for lactate clearance is a 2C. Measuring SVO2 for that subgroup of people that I mentioned that was appropriate is a 1C. Now what about vasopressors? What's the most appropriate? Anybody know what the recommendation were in the 2008 document? It was either norepinephrine or dopamine. That was the recommendation in the 2008 document. And we're going to go through the history here in a minute. Now, when I was in training in the 1970s, has anybody ever heard of the drug called aramine? Guess not, okay. You did? Okay. Well, aramine was our first drug we went to when patients became hypotensive. And then if aramine didn't work, we went to this drug called Levofed. And the thing was, if you went to Levophed, you left them dead, right? It's a true story. Isn't that right? Not okay. So then dopamine became available. And now everybody who was hypotensive got dopamine. If you did low-dose dopamine, it was supposedly renal sparing. And then all of a sudden, norepi vanished. So in the mid-1990s, a study came out in Chest that said that norepinephrine actually might be, or norepi, excuse me, may be more effective and reliable than dopamine at reversing septic shock. In 2000, a similar article showed that outcomes were better of patients who got norepinephrine versus those who got other vasopressors. In 2006, an observational study suggested that dopamine administration may be associated, in fact, with an increased mortality rate. This is really blowing all my training to bits. Okay? And they recommend that a prospective study be done to compare the two. Well, guess what? A comparator study was done, published in the New England Journal in 2010. They found out there really wasn't any substantial difference in outcome, but they found out that dopamine was associated with more cardiac arrhythmias and a higher mortality rate, especially in those patients who had underlying cardiac disease. Wow, now I'm really confused. And this is the Kaplan-Meier curve, which you can see, although not statistically significant, dopamine had sort of a trend, but not statistically significant over dopamine. And then this large meta-analysis in the Journal of Intensive Care Medicine showed that outcomes in mortality clearly favored norepinephrine, which is on the left-hand side of this line, and that for cardiac arrhythmias, there was a much greater protective effect against cardiac arrhythmias if you gave norepinephrine. And then this last meta-analysis published at the end of last year showed exactly the same thing, looking at treatment of septic shock. Again, if you're the right-hand side of this line, it means that norepinephrine was better in terms of outcomes, and it is statistically significant. This is just a list of the vasoactive drugs and how they work. Norepi, of course, has a slight increase in heart rate, a little better contractibility, but has a pretty good arterial vasoconstrictive effect. Dopamine, you can see, is about the same except for arterial vasoconstriction. And you can see the other drugs. The only drug that I'll sort of point out that phenylephrine is sort of an interesting drug that has the same vasoconstrictive effect as norepinephrine, but has no effect on heart rate. So if you have that rare patient that's got a heart rate of 140, 150, and they're hypotensive, and you don't want to further increase their tachycardia, that may be a place for phenylephrine. And then this article is showing that low-dose dopamine does not improve renal dysfunction. And in fact, in the Surviving Sepsis campaign, both the old one and this one, the recommendation is do not use low-dose dopamine for renal protection. It's got a category 1A recommendation. So where do we stand now with vasopressors now in 2013? You want to maintain your mean arterial blood pressure above 65. Norepinephrine, not norepinephrine and dopamine. Norepinephrine is now the first choice of vaso. There's very little indications now for dopamine. Then it suggests that epinephrine may be added potentially to substitute for norepi with an additional agent needed to maintain blood pressure. As I mentioned, if they're severely tachycardic, phenylephrine may be useful. Vasopressin may have a role. And then the last thing, once again, low-dose dopamine should not be used for renal protection. So the big change in the guidelines is that dopamine's dropped out. And then for inotropic, part of the early goal-directed therapy, they still recommend with a fairly high level of evidence that dolbutamine infusion should be admitted or added to vasopressors in the presence of myocardial dysfunction, as suggested by either elevated cardiac filling pressures, low cardiac output, ongoing signs of hypoperfusion, which could be elevated lactate level, or decreased SCO2. Steroids. I'm going to give you the whole history of steroids because that would take too long. But steroids we thought were dead due to studies that came out in the 1980s, until the Anand study came out in 2002 suggesting that a subgroup of patients that you gave low-dose steroids, we're talking about 50 milligrams of hydrocortisone, 4 times a day. It's really just a little bit higher than replacement dose, might improve outcome in a subgroup of individuals. And then this study came out in the New England Journal in 2008, and without going through a lot of basic science here, which is not necessary, steroids did not improve outcome, but I have to tell you that the mortality rates in this study were much lower and lower than was expected. If you look at the Anand study, look at the mortality rate, between 40 and 60%. When you see rates that way, almost anything can bring those rates down. Okay, it's true. But this study, the mortality rate was much lower, so it turned out it wasn't powered to show clinical differences, but what it did show was that steroids seemed to improve shock reversal. It didn't influence outcome, it didn't increase length of stay, but you got off vasopressors faster. And this is the Kaplan-Meier curve, and I won't go through with the cortisone stimulation tests, et cetera, but hydrocortisone seemed to get people off pressors faster. And then in this large meta-analysis a couple of years ago, if you look at outcomes of mortality with steroids versus control, it is not statistically different. However, shock reversal was statistically improved for patients who got low-dose hydrocortisone. So what do the new Surviving Sepsis campaigns say? First of all, it suggests not using intravenous hydrocortisone as a treatment of adult septic shock patients if adequate fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. In the case that it's not achievable, we suggest intravenous hydrocortisone alone at a dose of around 200 milligrams per day. But look at the level of evidence. It's a 2C. It's a very soft level of evidence. So a lot of our evidence-based order set says you can consider using that if the patient has vasopressor-dependent septic shock. And now we're not talking about people on vasopressor for a couple hours. We're talking about people who have gotten fluids, they're on vasopressor, and you can't get them off. Okay? And they suggest not using an ACTH stimulation test. I won't go through the science on that. Glycemic control. We had a nice discussion with some of your surgeons a little bit earlier in a different venue. There's lots of reasons why elevated glucose impairs immunity. And these are just some of the things that have been listed. In particular, it's the impaired leukocyte function, which is really the significant part. Now, what really started this discussion, and when I got into the sepsis thing for the transformation of the ICU, the Vandenberg study had just come out in the surgical intensive care unit. Now, for those of you not familiar with the Vandenberg study, she looked at tight glucose control between 80 and 110 versus 180 to 200 in a surgical intensive care unit, and that's important. They noticed increasing mortality, decreased mortality, bloodstream infections, renal problems, and decreased need for transfusions. And here's the Kaplan-Meier curve in terms of in-hospital survival. The majority of her patients in her surgical intensive care unit were cardiac, just to let you know what the population was. Then in 2003, in sort of more of an observational trial, they found out that hyperglycemia was associated with increased risk of death, and that by using some regression models, they found the mortality benefit seems to occur if you can keep glucose level less than 145. Remember, Vandenberg, tight glucose control, 80 to 110. So just keep that in mind. Then the Mayo Clinic proceedings looked at glucose maintaining it less than 140. They put people on continuous insulin infusion. That's what CII is here. And if they kept the glucose below 140, there was a significant reduction in mortality, end organ dysfunction, length of stays in the ICU. So we're getting the feeling is that poor glucose control with glucose levels persistently above 200 is bad. And that if we can keep it under some reasonable control, we can improve outcomes. And then the second Vandenberg study in a medical intensive care unit was a little bit more confusing because the only group that benefited with this were individuals who were in the intensive care unit for greater than 3 days. All the other ones, there was no statistical difference between normal glucose control, which was 180 to 200, versus 80 to 110. So, some of us are sort of scratching our head now. Okay? And then this study came out in 2008. I just really want to draw your attention to the insulin therapy, not the pentastarch. What they found is that the intensive group, the infusion of insulin, was started when glucose levels exceeded 110. We're talking about really strict control, okay? In the other group, the insulin levels were maintained between 180 and 200. So that's pretty similar to the Vandenberg protocol. This was the survival rate, no difference. And in fact, there was more severe hypoglycemia in the intense therapy group. And unintended consequences. And then this study came out a couple of years later, and I love the name of the study. It's called the Nice Sugar Study. Isn't that a nice study for this? They looked at glucose levels between 80 and 110 essentially, and less than 180 for more routine glucose control. Their primary endpoint was death of any cause within 90 days after randomization. It turns out the intense glucose group actually had an increased mortality rate compared to those people who had glucose levels of less than 180. So now we're really scratching our heads. So it looks like too tight is not good. No control is not good. So what's the sweet spot? Well, the new guidelines say that you want to keep glucose levels less than 180. That seems to be a reasonable level, but that high levels are bad. And if you try to get too tight with glucose control, the patients are going to have worse outcomes and more severe hypoglycemia. And that, by the way, gets a grade of 1A. So even early on in our sepsis campaign, we had already reduced ours to less than 180. Now, what about supportive therapy? The only one I'm really going to mention is low tidal volume for patients who are on ventilators who have acute respiratory distress syndrome. Low tidal volume being 6 cc's per kilogram rather than the 10 to 12 that we used to use on ventilator patients. And you can see there's significant decrease in mortality by using low tidal volume. Again, the hypothesis of this, by not stretching the alveoli and not injuring basement membrane, that the patient gets off the ventilator faster. In fact, that's been proven by other studies. So in the Surviving Sepsis campaign, this actually gets a 1A grade, also maintaining peak pressures at less than 30 is a 1B, and then recommending positive end expiratory pressure be applied to avoid alveolar collapse at end expiration. So low tidal volume for patients who have ARDS. Now what about outcomes? Well, this was the study group that I was involved in that published this in 2007. And here's our initial data. We started in 2003, and I told you half the elements we used are no longer recommended. We used tight glucose control as an example. You can see our mortality rate came down significantly from our baseline. This was our ramp up, and here is our final implementation. These are all comers. Our length of stay also came down in the ICU. There was a strong trend, but it did not quite reach statistical significance. Now you notice our initial data was presented actually at the IHI National Quality Forum in 2004. You know what came after this? The IHI Surviving Sepsis campaign. This was the basis for that campaign. If you look at compliance with the bundles, they were looking at a 6-hour bundle and a 24-hour bundle. As I said, the new guidelines are really emphasizing the 6-hour bundle. You can see the compliant group had much lower mortality than the non-compliant group. This one was 6 hours. This was the 24-hour bundle. You can see at both areas, compliance lowers mortality. Bundle implementation and decreased mortality. Mortality who completed the bundle were significantly lower than those who did not complete the bundle. This is not surprising, 21% versus 40%. Completing early goal-directed therapy in 6 hours. You remember the resuscitation bundle? Those patients who require early goal-directed therapy, which is the minority, not the majority, had a significant reduction using multivariate analysis. And after 2 years, they achieved a 51% compliance with all 5 of the key indicators. Now, you may think, 51% compliance, that ain't so good. It was an all or nothing. If you didn't hit all 5, you didn't get credit for it. So it was a binary thing. And then in 2010, I put this article in because I think it's important. This is the impact of surviving sepsis on length of stays and mortality. These were all patients, by the way, with septic shock. So these are your sickest patients, because a lot of the other studies I mentioned were a combination of severe sepsis and septic shock. The mortality rate was reduced by 57% from historical controls to 37.5%. We're going to come back at the end about targets. Again, the compliance with 6 or more interventions in 6 hours was an independent predictor of survival, and the only single intervention with the impact on mortality was achieving an SVO2 of greater than 70%. Again, coming back to why measuring some of these things improves outcomes. This is using a standardized order sets. I assume that most of your hospitals now have standardized order sets. Now, why do we use order sets? Is it cookbook medicine? No. We use order sets so that we don't forget all the bundle elements. I can't keep them all straight in my mind. And the other thing I tell groups over and over again, that order sets are not meant that have to be followed every single one on every single patient. They have to be applied to the patient that you're seeing. So don't feel obligated that you have to check off everything in an evidence-based order set if it doesn't match your patient. But when you use these order sets, you're more compliant with the essential bundles, and in fact, your mortality rate goes down. This looks at the group that started screening patients, like we're doing. And guess what? If you screen and you pick up these people early, guess what? Your survival rate is better. And when I go to your CFOs, you know those people in the C-suites that we all love? And any CFOs here? Careful, huh? I love them, actually. The key thing about CFO is you bring them into the discussion early. They're really good people. They want to do the right things. It's useful for us to hear their side of the equation. It's useful for them to hear about the clinical importance of what we're doing. And I tell you, more often than not, you'll be surprised how our efforts are synergized when we talk to one another. And get them involved early. Don't go to the C-suites without a business plan that hasn't been looked at by your CFO, because I can tell you I've seen some really ugly things happen as they shoot down everything you present. But there is a very strong financial case for this. This is just one example about implementing a protocol, reducing mortality rate, reducing length of stay, and significantly reduces cost. And what I put at the bottom of this slide is that there's no sustainable business model without quality. I really, really believe that. Now, I'm getting back to this chest article. It looks like the frequency of severe sepsis you see has gone up in this article published at the end of 2011. But look what's happening to mortality, folks. With the Surviving Sepsis campaign and the evidence-based interventions, we're getting our arms around mortality. Now, this is a slide I want you to remember when you go back and look at targets. This is from that same article in Chest at the end of 2011. By looking at their data, they say the percentage of septic shock patients have actually gone up in the last decade. Now, some of our facilities have experienced that. Some of us have experienced just the opposite. I'm hoping we're going to see the opposite because we're recognizing folks earlier. The in-house mortality for severe sepsis declined from almost 40% down to 27%. This is an article in 2011. And septic shock from 47% down to 36%. So when I look at targets for us, we've sort of set a target. We want 35% or less for shock and 25% or less for severe sepsis. And I think that's achievable, and many of our hospitals are doing that. Now, the other key bullet point is the last one. Survivors experienced a significant increase in number of discharges to skilled nursing unit and home health care. They don't necessarily go home healthy, guys, which is why if they're in the hospital, infection prevention is critical to prevent them from getting infections. If we recognize them early, they have less organ dysfunction, they're better. This article really says a lot. It talks about cognitive dysfunction in patients who survive. You know, we can bang our chest and say, we pulled the patient out of the fire, but they went home, they were not completely intact. If they had a very high mathematical job, all of a sudden they couldn't do their job as well, their productivity went well. Sometimes they couldn't work. And if you look at this article, 15% of people after sepsis had moderate to severe cognitive dysfunction. So not all of our patients go home well. The next thing is this article that just came out. It's a cohort prospective study in 26 adult ICUs in Scotland. Anyway, they looked at mortality measured by clinical databases, but what they did is they looked at a quality of life, which is a very common, they use a common short form, SF36. And they looked at it 3.5 and 5 years later after surviving severe sepsis. Patients with severe sepsis had a high ongoing mortality even after they survived and went home. They died sometime later, not always of sepsis, but of other things. They also had a significantly lower physical quality of life compared to their age-matched controlled population. And like the prior study, their mental quality of life scores were below the population norms for up to 5 years after sepsis. Now we always think about what happens in the four walls of the hospital. I look at things about societal costs and what happens to our patients. So I'm going to end on what I think the keys to success are. You've got to engage the key stakeholders in overseeing implementation, and that means physicians, micro, coordinators, etc. You've got to have agreed upon measures. You have to have enough resources and coordination. You have to have strong physician leadership, reminders and checklists, empowering the nursing staff, because the nursing staff's with our patients 24/7. They know when things are happening to patients. Use tools like Muse up on the floor. Work with your administration to try to overcome certain barriers. Review your data every month. Look for improvement. And by the way, celebrate success. It's really fun. Underlying all of this is the leadership and culture of your individual facility. We can give you tools and we can give you the science and we can make suggestions, but ultimately, as I said in the beginning, local implementation based on your workflow, based on your resources and your culture will make your program a success. These are the key elements. The clinical excellence must be a core value. We've already gone through the steps about the environment that you work in, knowing the definitions, knowing the new treatment standards, which I've gone over with you this evening, and then the steps of recognizing, implementing aggressive interventions, measure, track, and evaluate outcomes. And if you can't measure it, you can't manage it. And so here are the now endorsed NQF measures. This might be something, we're looking at these. Within 3 hours, measure serum lactate, appropriate cultures before antibiotics, broad spectrum antibiotics and fluid resuscitation at the 30 mLs per kilogram crystalloid. Within 6 hours, again, this is a tiered approach. If you're persistently hypotensive or you have an elevated lactate level, you measure CVPs and you measure SVO2s. I put in parenthesis what the targets are, but in the proposed measures, we realize there's too much individual patient variability to hold people to a standard to achieve those measures because it may not be possible in some patients. So the measure is a process measure. You just need to measure the CVP and you need to measure SVO2. By the way, there are exceptions for why you may not be able to measure SVO2. Teamwork's the key. It's the key to everything that we do in healthcare, actually, whether it's sepsis, whether it's antimicrobial stewardship, infection prevention, medication safety, all the things that we do. So I want to finish with these two cases. I know you've been on the edge of your seat to try to figure out what these two cases said. So what about this case? What is the skin changes here? It's got blisters, right? It's got sort of a hemorrhagic blister, doesn't he? And he's got pain out of proportion. And when you see that, and then, by the way, this was a diffuse cellulitis on presentation with pain out of proportion. You're correct. This turned out to be necrotizing fasciitis. The organism that grew from the blood and from the leg was Group A strep. All right? So let's talk about the antimicrobial management of this patient and what we might do differently. This is a great article in Medicine that talked about people who have diffuse non-culturable cellulitis. By overwhelming, these people have a beta hemolytic strep, which is how he presented. So think about the initial antibiotic management on this patient. It was vancomycin and piptazo. If we were thinking necrotizing fasciitis and we were thinking about group A strep, might we think about at least adding a drug for that clinical symptom? The answer is clindamycin. This is a toxin-related disease, and the addition of clindamycin to a penicillin improves outcomes. He survived, by the way, but he had obviously debridement. This is as much a surgical disease as it is a medical disease. Now, how about that other patient, 24-year-old, recurrent urinary tract infection, poorly controlled diabetic, comes in with classic pyelonephritis, been on an antibiotic course for mastitis about a month ago, and presents with this CT finding. I'll show you. What's this? Gas. This patient's got emphysematous pyelonephritis. This is something almost always seen in poorly controlled diabetics. Now, let's think through empiric therapy on this patient. Do we have a site of infection? Yes, it's the kidney, right? What's the most common organisms to cause pyelo? E. coli, correct? All right, so so it could be gram-negative. We know what the site of the infection is, correct? So is this a patient I'm going to be using vancomycin on? I don't think so, but I will tell you a lot of times people who get put on vancomycin, okay? So it's probably a gram-negative. Gram-negatives produce gas, so this was perfectly consistent with this clinical and radiographic picture. The question is, what are you going to start this patient empirically given this review I mentioned 30 minutes ago, where your failure is more likely in patients who have received prior antibiotics. This is not that easy. Now, in most facilities, they look at their local antibiogram, and Dr. Colon can correct me, but you probably have about a 30% resistance to fluoroquinolones to E. coli, correct? And about 30-40% resistance to trimethoprim sulfamethoxazole, which was those are our two heavy drugs for pyelo and urinary tract infection. So a lot of facilities are looking at their cephalosporins, increasing resistance to E. coli to first-generation cephalosporins. You'd have to know what your local susceptibilities were. But a lot of people are saying, well, 90+% are still susceptible to third generation. Am I correct? Okay. So a lot of facilities in this case would empirically start these patients out on ceftriaxone. The question is, for this patient, would you be comfortable with that alone? And the answer is, I will tell you in retrospect, I'm doing this knowing the answer, so I have to be honest here. Okay? But because of her prior antibiotic history, maybe she's got an ESBL producing gram-negative, which would be resistant to the third and fourth generation cephalosporins. I don't think she's going to have a carbapenem-resistant organism, ambulatory patient. So if she thought she had an ESBL, then what drug would you start the patient on? You'd probably start them on a carbapenem. I'm breaking every rule that I teach people. Don't use carbapenems. In fact, this patient had an ESBL-producing E. coli both in the blood and the kidney, and in fact, this patient had to be treated with a carbapenem. So again, knowing her prior antibiotic history, this is why I put this back on there. You're much more likely to have a multi-drug resistant organism if they've been on prior therapy. She had a couple of different courses for UTIs in the last year. This recent episode for mastitis, she was very clear for UTI, she got 3 days. So she probably got a fluoroquinolone. So I'm going to end on this slide. You've been a great audience. I wanted to finish by 7:30. I did. A lot of material. I hope some new information for those of you who've heard this before when I've been here before. There's a lot of new information here that was not in my prior stuff. I did not go through the whole history of the evolving science because that's not appropriate for this sort of a CME. But I'm happy to, those of you who need to go, I completely understand. I'm happy to stick around and answer any of your questions. I really sincerely mean this. You've been a great, respectful audience, and I hope this was of value to you to keep you away from your families. But I hope the hors d'oeuvres are pretty good, though. So at least it was worth something, right? So thank you very much.